So it is my great pleasure to introduce Dr. Giles Robinson, who is an associate member in our Division of Neuro-Oncology here at St. Jude. So Dr. Robinson completed his undergraduate training at Boston College and his medical training at Brown. He is, I would say, sort of a definitely has already risen star, a real star here at St. Jude Children's Research Hospital in our medulloblastoma clinical program, doing really cutting edge incorporation of genomic analyses and clinical trials. So he is really very, very insightful. I think this initiated or was at least first fully pursued during his postdoctoral fellowship training in Richard Gilbertson's lab, really digging into molecular signatures of medulloblastoma, which resulted in a beautiful genomic landscape paper. And he's been continuing to take advantage of large patient cohorts and work together very closely with Paul Northcott. Together, the two of them as a team have really identified a number of much more defined subgroups, molecular subgroups of medulloblastoma, which Giles is incorporating into sophisticated clinical trial design, stratifying patients with a much greater rationale and also selecting specific therapies that should be more effective at targeting particular subgroups. So today he'll be talking to us about this, tailoring his therapy to fit the molecular landscape. So thank you, Giles.
Let me just jump into the presentation here. So, I mean, you guys heard a lot from Mariella about the evolving landscape of pediatric brain tumors, and really our jobs as oncologists is to take that information and apply it to our therapy. And so instead of talking about high-grade glioma like she has, I'm going to talk about a different disease, which is called medulloblastoma, kind of review the disease and its therapy, and then discuss how recent advancements have transformed our understanding of this disease, and then discuss how this knowledge can be used to improve our therapy. And throughout this talk, I hope I can share with you a vision of how to kind of use science and medicine to what I think continually better and understand the disease as well as cure these devastating diseases. So as many of you may know, medulloblastoma is an embryonal tumor. It forms in the posterior fossa, which is just the area that houses the cerebellum and the brainstem in the skull. And it is among the most common malignant brain tumors of childhood, but brain tumors in childhood are really quite uncommon, and so only about 400 cases happen in the United States a year. And it can present in all age groups, but it's most common between the ages of 3 and 9. Now, if you're diagnosed in this country with medulloblastoma, you're more likely going to receive this type of therapy. And that would be that the tumor is surgically resected as best as possible by a neurosurgeon. And then you undergo a staging procedure where you're judged as to whether you have metastatic disease that is spread around the brain and spine or non-metastatic disease that hasn't spread. And based on really that rudimentary factor, you're assigned to treatment therapy. And the real difference between the two is the high-risk metastatic disease gets a higher dose of craniospinal radiation therapy, and the non-metastatic disease gets a lower dose of craniospinal, but still craniospinal radiation therapy. And then we chase that as oncologists with chemotherapy. And everybody's got their little favorite cocktail, depending on what institution you trained at and stuff. But what ends up happening is that patients with average risk disease really come out with about an 80% survival, and patients with high risk disease come out with a 60% survival. But this survival, which is in the range of 70 to 75% total, comes at a cost. And so when we do surgery, radiation, and chemotherapy, we inflict known damage on these patients. And unfortunately, the younger you are when you receive these modalities, the higher the risk is. And so, in my opinion, what's truly wrong with standard therapy? Well, you heard a huge amount of molecular insight from Mariella about high-grade glioma, and we have the same in medullo. And yet we're not really using that insight in this current modality of therapy. And what we found out over the past few years is that the disease is really far from being uniform at all. In fact, medulloblastoma is made up of 4 different subgroups, and these subgroups have been found to be molecularly and clinically distinct. They're so distinct that they happen in different ages of childhood. They happen in different genders, with group 3 and group 4 medullo occurring more commonly in males, whereas Wnt and sonic hedgehog are more evenly balanced. And they have different genomic drivers, like this catenin gene for the Wnt group versus the patch gene for the sonic hedgehog. But the most important thing is when we actually look at survival based on these subgroups, we see that 70 to 75% overall survival of our patients is actually an average. It's not a completely common scenario that comes out with patients surviving almost 100% of the time when they're getting the same type of therapy as group 3 patients who are surviving at 50% of the time. And that gives us insight on how we can improve our therapy. If we understand the disease like that, then we can actually critically evaluate therapy like I just did and say, why are we treating Wnt patients with the same kind of intensity that we're treating our group 3 patients and coming out with very different outcomes? And so our job then is to carefully introduce change without compromising on our past success. But before we've been able to do that, we actually took these 4 subgroups and we looked at our laboratory data that we had, and we found that in the lab there was only really one model that anybody was investigating of medulloblastoma. And that model was a sonic hedgehog model, meaning that 75% of the disease wasn't being studied in the laboratory. And it was once these subgroups were found that people started to investigate whether other groups of medullo could be formed in the laboratory to give us some insight and something to work with in order to build our clinical trial. And so Richard Gilbertson introduced an activated beta-catenin gene and formed a Wnt model, and Martine Roussell's laboratory introduced a MYC amplification, which is commonly seen in group 3 into cerebellar precursor cells, and established a group 3 model of disease. And this was hugely important to us because, like I said, we had been working in the laboratory with sonic hedgehog models, and we had actually come up with some sonic hedgehog inhibitors called smoothen inhibitors that were really a flop in the clinic, largely because we were trying to get sonic hedgehog inhibitors to patients who didn't have sonic hedgehog disease. And so we now had a reason as to why these patients weren't doing well, and we also had other tumors to investigate as to what tumors or what drugs would be especially effective in treating these diseases. And that's exactly what we did with a kind of a crack team of pharmacologists and chemists. We looked at these group 3 medulloblastoma cells, and we tested a series of compounds against them. And we were really excited about finding a couple compounds that were already readily available and ready to use in the clinic. And these were gemcitabine and pemetrexate. And when Martine's group put gemcitabine and pemetrexate into mice, we could see that their survival actually increased. But it increased basically the same as if we gave them our standard chemotherapy, which is CC here, or cisplatin and cyclophosphamide. But what was telling was when we actually alternated and combined the two together, we saw that the survival curve increased significantly. And this was without radiation and all of the other surgeries and stuff that we do for kids. So this was the fuel that Amar Gajar and I really needed in order to build the first molecularly stratified medulloblastoma trial to take some of these findings into the clinic. And in this trial, we've been able to split patients into 3 of the 4 subgroups, Wnt sonic hedgehog and non-Wnt non-sonic hedgehog, which encompasses all of that group 3 and group 4. And by simply doing that, we're able to isolate out these Wnt patients and give them a lower dose of radiation to patients who are already doing really well so that we can improve their quality of life. Lo and behold, we're able to give sonic hedgehog inhibitors to actual sonic hedgehog patients, which now seems rudimentary, but at the time was fundamental. And using Martine's discovery of pemetrexate and gemcitabine in the mouse model, we were able to introduce that very therapy into the most aggressive form of non-Wnt non-sonic hedgehog, which are normally our group 3 tumors. And that has been hugely successful, and we have accrued more patients than we could have ever imagined on this trial, and hopefully I will soon be able to publish some very exciting data for you. But all of that stuff that I've explained to you really happened in 2012, 2013 when we were launching that trial. So what have we done since? Well, we've really been doing a lot of the same, and that's understanding the disease a lot better. And so Paul Northcott, who is here at St. Jude, has now been able to look at thousands of medullos as opposed to just hundreds of what we were looking at before. And by looking at those thousands of medullos, we've been able to see that there's quite a bit of heterogeneity that exists within these 4 subgroups of disease, which is also fascinating and kind of gives us some treatment insights. So what you're seeing here is something that we call a TSNE plot, but it basically assigns molecular coordinates to tumors, and if the tumors are like each other, then they cluster together. And so what you can see here is the Wnt group is a very homogeneous group that all clusters together, but the group 3 and group 4 tumors have quite a bit of variety within, and so do the sonic hedgehog tumors seen over here. And so people like Paul and our colleagues in Germany and Toronto have shown us that this is not random heterogeneity. This is actually very specific. And so by dividing the subgroups into 8 subgroups, Paul is able to show here that the KDM6A mutations that are common in kind of group 4 disease really only occur in this subtype 8 that he's highlighted here. And similarly for the sonic hedgehog group, the P53 mutations really only occur in this sonic hedgehog kind of alpha group. But what does that mean clinically? Are these things actually clinically relevant, or are they just kind of good for science and understanding? And to highlight a story that shows that they are actually clinically relevant, I'll take you through a study that we did in 2018 that focused on our youngest population. And our youngest population are the most vulnerable to radiation therapy. And we've done trial after trial trying to omit radiation, craniospinal radiation therapy from this population. But that has not worked out very well. It hasn't been a complete failure, though, and there's somewhere between a 30 to 50% survival rate in some of these younger children who are getting these chemotherapy-only regimens. But 50%, even at its best, is not good enough. So I asked Paul to have a look at all of the young children that we were able to gather, and we looked at about 200 patients here and looked at the different subgroups that were coming out. And surprisingly, there are no Wnt tumors in this group. And in fact, there's a high proportion of sonic hedgehogs, and there's a high proportion of group 3 cases. And when we looked at the survival on our latest study, or progression-free survival, we saw that there was really only one group that was actually benefiting, and that was the sonic hedgehog group shown here, whereas the group 3 and group 4 tumors were all progressing with disease. They could be salvaged with radiation therapy, but that was the very therapy that we were trying to avoid in the first place. But 50% again in the sonic hedgehog group wasn't a satisfying number. So we looked for subtypes within the sonic hedgehog group and found these 2 subtypes could be isolated. And when we looked at the survival between these 2 subtypes on this relatively lower intensity chemotherapy regimen, we saw that our sonic hedgehog 2 subtype outperformed our sonic hedgehog 1, which was a huge finding to us because it's now built our next infant medulloblastoma trial, where we can take these young children with medulloblastoma and divide them into sonic hedgehog and non-sonic hedgehog or group 3 disease. And we can take these sonic hedgehogs and divide them by their subtypes into sonic hedgehog 2 and sonic hedgehog 1. And in doing so, we can highlight a portion of the population who we hope we can treat with a lot lower dose of chemotherapy than other protocols treat them, and still have them survive the disease without all of the toxicity. We plan on giving a more intensive chemotherapy to the Sonic Hedgehog 1 group, which others have shown has actually worked quite well in the Sonic Hedgehog group of infants. And finally, for these group 3 and group 4 cases who unfortunately really need radiation to survive, we're taking an approach of giving them chemotherapy in order to get them older and then starting that radiation therapy at hopefully lower doses so that they will not get as affected by the radiation therapy itself well before they relapse with aggressive disease. We're doing the same thing with our older patients. Our older patients, as you remember, are doing quite well on therapy. However, we're still trying to push beyond this 80% threshold. And so what we looked at were these non-metastatic group 3 and group 4 cases. And we looked at these very subtypes that Paul Northcott has been able to pick out. And we were able to show kind of their risk on this forest plot. And so if you're on the right side of the forest plot, then you end up having a higher risk of relapse. And if you're on the left side, then you have a lower risk. And just by looking at all of these patients who are basically identical and get the same therapy throughout, we see that if you were subtype 3 or MYC amplified, you had a much higher chance of relapsing than those patients that didn't. And interestingly, if you were subtype 7, you had a much lower risk of relapsing than the other group. And this same idea is kind of plotted out here on a survival curve, which shows these subtype 7 patients up here in blue as having a survival that rivals that of the WINT cases that I showed you before. And it really gives us some fundamental insight into how we could further risk stratify therapy within these groups. We did exactly the same thing with our Sonic Hedgehog patients and showed that there were certain mutations in the Sonic Hedgehog group that put these patients at extremely high risk of relapse. And when we plotted those patients out with the ones that were at high risk with those mutations versus the ones that didn't have those mutations, we saw an amazing separation of the curve, again giving us ideas of how to treat these patients with alternative therapy that are in the high-risk group and how to back off on therapy of those other patients that are in the better-performing group. And so what I'm doing now is constructing a trial in kind of brainstorming with all of this information to see if we can use this information so we can follow up our MB12 trial with a follow-up trial that does even more than what we did in MB12. And by using that same strategy that I've been talking about and identifying these low-risk patients, we estimate that we can now reduce craniospinal dose to potentially 40% of the patients, as opposed to 10% of the patients that we were able to do for the WINT group. And we're also looking at the highest risk patients and seeing if we have some of the most exploratory therapy that's coming out of our laboratory, so we can treat those patients who don't do well on our current therapy with those. And finally, I do want to bring up one thing, because all of our risk stratification is based on your molecular profile at diagnosis. And what Paul Northcott and I were able to do is to actually recently publish in Cancer Cell that we're able to detect disease, microscopic disease, or circulating cell-free DNA within the CSF of patients long before that disease comes out as an actual relapse. And this is, like Mariella had said, this is kind of taking a cue from leukemia, and because they've been able to adjust their therapies based on presence of disease detectable during therapy. And what we did here, so Amar Gajar and Richard had the foresight of saving serial CSF samples for years, and we waited until the technology was right. And recently, the technology has allowed us to actually detect evidence of cell-free tumor DNA within the CSF. And this is a diagram of the chromosomal abnormalities that you see in the tumors at diagnosis. And this is a CSF sample that's taken also around baseline kind of diagnosis time point. And you can see the similarities between the copy number changes that are coming out on the tiny little amounts of DNA that are being extracted from the CSF. And one thing that we saw, which was really quite interesting, was that when we started therapy on these patients, sometimes the circulating tumor DNA went away and then came back again as a relapse. Other times it never completely went away, and other times the patients were cured and it never came back again at all. And that was the information that we needed to really launch into a major study on all of the frozen samples of CSF that we had here in our tumor bank. And what I'm showing here in these two kind of swim lane plots are patients who have progressed on this side and patients who haven't progressed. And at baseline, as early on, you can see that there are lots of red dots in both columns. And this means that we can detect disease at baseline. But once treatment starts, you can see over here that the patients that aren't going to progress, their positivity or red dots go away, whereas the patients that do progress continue to have red dots throughout different time points that we checked throughout the study. And this is demonstrated in these two kind of survival plots, because at baseline, there's really no difference between the patients who had positive and negative disease in their CSF in their survival. But if you have positive CSF findings of tumor DNA in your CSF at the end of therapy, then you will have a much lower survival or a much higher chance of relapse based on that finding alone. And that gives us something that we can do, a molecular measure of kind of treatment response that allows us to actionably act and maybe give that patient more chemotherapy during therapy. And so I'm sorry I kind of ran out of time and had some technical issues, but I hope what I presented to you is a kind of a critical way of thinking about disease and thinking about using all of these great molecular findings and how we as oncologists need to insert that into the care of our patients. I think we've come such a long way in the last 10 years, and I really believe our future is incredibly bright as we take this knowledge forward. And of course, I have too many people to thank in too little time, but this has not been a single effort. It's been an effort of a lot of people. And I'm truly inspired by my patients and families in order to take this therapy forward. Thank you.
Thank you, Giles. Spectacular work, and you impressively really managed to make it before the end of the hour. So I'd like to encourage people to go ahead and add questions to the chat, please. Any questions for Dr. Robinson? And one of the questions that I would like to ask, there's this beautiful refinement of classification of the tumors that's really both genetic and clinically relevant. So I'm just wondering, do you think you're going to get to the point where more subtle changes will cause a tumor to shift from one refined category to another? Let's just say you acquire a MYC mutation or something that, that happens. Right now, those categories are really pretty solid, as in they don't easily shift. Do you think you're going to get down to such a fine tuning that you might be able to see some shift between categories?
Yeah, I mean, some are very stable, like you mentioned, and then others are probably derived from kind of cells of similar lineages. And we particularly think that, and Paul has started to show that looking at the group 3 and group 4 tumors, because they've never been able to completely separate, and they do have a lot of overlap between the two. And so what Paul showed in one of the relapse studies was there were actually a couple of cases that kind of migrated from being group 4 into kind of a group 3 lineage. And that may be because of the pressure of the treatment that we're giving is forcing those cells to become kind of more aggressive and we think kind of less mature over time. So I don't think we're going to see true switches from Wnt to Sonic Hedgehog, but I do think within the Sonic Hedgehog groups or within the group 3 and group 4 we can see that migration.
Great. So it's actually the top of the hour. And so I definitely want to welcome any participants who would like to stay for an extended Q&A session. We're really appreciate that both Dr. Philbin and Robinson will stay a bit longer for ongoing discussion. But I will sort of formally close the session for those who need to move on to another meeting in their day. I want to thank all of you for coming and invite you to come back next week, November 18th, where Dr. Doug Green, who's the chair of our Department of Immunology here at St. Jude, will present the last lecture of this fall 2021 series of Science of Childhood Cancer. His talk is entitled Persister Act, Near-Death Experiences in Cancer Cells. So please join us again next week, and feel free to stay and add additional questions in the chat for our speakers. So actually, we have some questions already coming in. So for Dr. Philbin, the first is a technical question. What was the platform for small nuclear RNA-seq and ATAC-seq? They're asking, were these the exact same cells as done in current 10x and other strategies?
Yeah, thank you for this question. So the single-cell RNA-seq was done both by 10x Genomics and by SmartSeq2. Not on the same cell, obviously, but in the same tumor, in order to get more depth by SmartSeq and more breadth by 10x, so more cells. And single-cell ATAC-seq was done by the 10x Genomics platform, but not on the same cell yet. We're working on the same cell platform. That's coming.
Great. Another question is, how did the regulatory genome change as the tumor differentiates? Did the astrocyte-like cells have astrocytic regulome or a mix of OPC and astrocytic regulome?
Yeah, also great question. And I didn't have time to go into the ATAC-seq data, but that's exactly what happened. Like as the cells differentiated, they first had regulatory circuits of both oligoastro and then went towards the astrocytic-like. So basically by single-cell ATAC-seq, we were able to reproduce those hierarchies we had seen on the transcriptional level. Seems like they changed a little bit earlier than on the transcriptome, like the chromatin opens up first or condenses first. But yeah, it's a similar hierarchy or the same hierarchy we saw.
Great. And one more question. Piyush Joshi is very active in their questions. Thank you for all the questions. For the G34R and V gliomas, you mentioned interneuron properties of tumors. Astrocytes are derived from DBX1 domains, among others, which give rise to interneurons. Would this entail these interneuron progenitors not turning off a neural program and starting gliogenesis, or do they de-differentiate into a neural progenitor state?
Yeah, that's a great question. So we think that indeed the most immature cell is still bivalent and can go down the neuronal or the glial route. If they go glial, it's mostly astrocytic in these tumors and not so much oligodendrocytic. So I think that's what's going on there. And the more interneuronal they become, the more they turn on GABA. But the more immature cells can still do both and doesn't yet have GABA produced. So that's true. So okay. More that than de-differentiation. I think it's more coming from an earlier cell that can still go down. But we haven't done the functional experiments yet to prove that it's truly one way and not as plastic as in the hemispheric GBMs.
Great, thank you. So I have a general question for both of you. I think these two talks are beautifully complementary in, both really digging into molecular features, but, on one side, Dr. Philbin's talk today is more about sort of mechanistic pieces of those molecular signatures, and Dr. Robinson, what's the clinical impact of this and how does this apply? So although there are different tumor types, I think that this is sort of the whole continuum of, and really the main feature here is the differentiation state, right? Or the cell state. Maybe it's where the tumors came from, maybe it's where they ended up. But in the end, it's all about this kind of refined classification. So I just wonder if you guys might want to each comment a little bit about what you think about the ability to really personalize the approaches based on these molecular signatures. How large do clinical trials need to be to address this, and how large does a cohort need to be? I thought it was, for example, really fascinating that in this larger cohort of K27M mutant tumors, you found this mesenchymal component in the thalamic, which you need a big cohort, right, to start to see some of these differences. So what are your thoughts about, the really big picture for rare diseases? How big do we have to get before we become true experts at really getting it just right for each patient?
Chelsea, you want to start?
Sure. That's not a small question. Yeah, I mean, I think we all are kind of developmental biologists kind of at heart and stuff, and believe that these diseases are, a malfunction of development. And so that's where we've got to kind of hone, all of our efforts in, is trying to figure out how to kind of tackle that and cause a cell that's now behaving badly to either kind of differentiate and go away, or to kill it off. But the amazing thing, I mean, is we're curing these diseases with probably barbaric type of therapy, but we are curing them. And so, I mean, one of the things that I brought up was not messing with kind of past success, but slowly introducing these changes. I think it's a long haul. I think we have to kind of slowly look at what we're figuring out, and then apply them kind of method-wise as we go through. But it's not an easy fix. I mean, the one thing with clinical trials as they are built, the one thing that we like to do with our clinical trials is, if we're investigating a disease like medulloblastoma, or we're investigating a disease like high-grade glioma, we need to be inclusive of all patients, because we're going to find out different things about different patients as they go through. And so if you start a very small clinical trial honing in on one thing, you may miss out your potential to pick up others. Now, I'm not saying treat everybody the same, because that's exactly the thing that I've been hammering on about not doing that. But keeping them under the same umbrella, right? So if you have innovative therapy, then do that on the group that you think it's going to happen, but still treat the group that you don't know exactly what to do, because we need to explore that group more and figure things out. So you've got to give them your best absolute shot.
Yeah, very much agree with you. I think the challenge will be to put the new target treatments into context. And of course, you can't do that right away. You have to have a phase 1, finding the dose and toxicity. But once you have that, it will be crucial, I think, to do what you just said, to build it on the backbone that we already have for certain tumors and see how it works there. And in terms of combinations or treatments, I also wanted to add that initially I got discouraged seeing all these many different subpopulations and heterogeneity, thinking exactly like what you said, Susie, like how can we ever target all of this? Now that I've done it for a few years, I'm a little bit more hopeful again, because the number of states doesn't seem to be, infinite. It seems to be the mesenchymal we had seen in the GBMs, the neuronal-like program we had seen in the posterior fossa A ependymomas, as well as now in the ETMRs and now in the G34s. So I think there's convergence again, just in different ways. So I'm hoping that there will only be, a number less than 10 or so, or 15, for what those cells can do. And then hopefully we can target them within that framework.
I think that's a really key point, just getting the big picture. Sometimes, it takes all these granular things to start to see a whole pattern emerge. And it's very exciting to see things moving in that direction. So there's another question in the chat from Oli Lohi asking, have you validated prognostic findings of smaller subgroups in external data sets?
Yes, we are. Well, we haven't published anything yet, but we're working. So as you may know, there were 2 huge trials that kind of ran at the same time as our big SJMB03 trial, which have come out of COG. And we have collaborated and worked together in order to assess all of the different subtypes within those groups. And that's exactly what we want to do. We want to have, they're slightly different therapies, so we want to see do the subtypes respond the same? Do they respond slightly differently? Is there any new therapy that we should be taking from those, or responses that we should be looking for? So I think this is just, it's an early step, and we have to look at these details in every single cohort of patients that we have, because there will be nuggets of information hanging out in there.
Great. And there's a follow-up question, which is, what is the current status of sonic hedgehog inhibitors in clinics? They're known to have serious side effects, for example, closure of growth plates.
Yeah, I've sounded the alarm on that one. It's not easy, and so I didn't have time to go into all of the details. But what we did on our trial was actually only, or now restrict, the patients who are getting sonic hedgehog inhibitors to patients who are fully grown or have sealed growth plates. And it's a major problem because, like I said, sonic hedgehog is very prevalent in the youngest kids. But we do have a very high survival rate with our current therapies in these younger kids with sonic hedgehog disease, and to give them another deficit of growth was just too much. So what we're investigating is more in the adult population, which thankfully have kind of more sonic hedgehog tumors, combination therapies with sonic hedgehog inhibitors to see how that's working. But the challenge is this, as we introduce new therapies, then you see new toxicities that you didn't expect to see or didn't really think was going to come out before.
This is really an inherent risk of noting the underlying developmental biology for pediatric cancers, right? If you disrupt these processes, it is not unexpected that there could be developmental consequences for sure. So that's clearly a big challenge.
It's a non-target effect. We knew it was going to be an issue, or we thought it was going to be an issue, but in the early phase trials, it didn't come out, mainly because the patients didn't respond, or they were non-sonic hedgehog patients that we were giving these inhibitors to, and they were only on the drug for a couple of months. And so when we actually saw, if you put a child on for kind of 6 months or more, that's when you see the growth plate changes. And so using it as a frontline therapy is not recommendable at this point, because it carries more toxicity than potentially benefit.
So I have another question, kind of going back to the comment about the convergence of different tumor types with potential targets. So, makes me think about designing clinical trials that are pooling together molecular signatures rather than particular disease types. And also sort of the intriguing aspect, for example, of the loss of K27 trimethyl in posterior fossa ependymomas, as well as, diffuse midline gliomas, and although not having exactly the same cellular signature, right? So what do you think about grouping some of these entities together, and the rationale for doing that in clinical trials?
Yeah, it's a great question. On the ependymoma side, I was so surprised to see that the recurrent ependymomas in particular look a lot like GBMs, like hemispheric GBMs on the single cell space. And Richard Gilbertson has shown that previously with mouse models beautifully, that when you put in ependymoma oncogenes or copy number variations, that what happens in the end is development of glioblastomas. So I think that we will see more for high risk patients in particular. Like Charles said, it's tougher on the lower grade lesions that we already, or on patients where we already have treatments that somewhat work well for some patients. So there it's probably more stratification. But for the high risk tumors, I think that would be an interesting strategy. And also, coming back to this idea of differentiation therapy, that as a pediatric oncologist, I love from medulloblastoma and from APML and such, we will have to be careful if and how that's going to work in high-grade lesions here. I have some hope that some tumors will be able to do that. Some others might not, because the plasticity in GBMs, again, is just so high and different. So a lot to learn.
we need some advances in delivery to
Yes, and that too.
right? That's really, I think that's an area that's really going to be critical to fully take advantage of this sort of knowledge.
Mhm.
So there's a question. Oh, go ahead.
I was just going to say about, I mean, it's hugely tense. So Mariella brought up, CDK6 inhibitors, and we've seen CDK6 inhibitors have an effect on medulloblastoma cells as well. And of course, it's used in breast cancer and being evaluated in a bunch of other diseases. So there's definitely overlap. I mean, we've known this since the dawn of chemotherapy, right? I mean, we all use a lot of the same agents throughout different diseases. But the danger also then on the other side is, a one type of therapy for all. Doses may need to be different, delivery may need to be different. So we just, when you're doing those early phase trials, sure, and be inclusive, but then as you're getting into the next kind of line of trials, make sure you're separating some of those out so you're really seeing your signal in your different tumors.
But you know what, that brings up a really great point. As you were talking, I was thinking it might be true that CDK6 inhibitors just behave better in a neuronal background, like medulloblastomas are, and like the G34s are to some degree, than in a classical glioblastoma or glial tumor where they have failed clinical trials. So that's along what Susie also said. That's very interesting.
Mariella, do you know what the copy number is? There are some focal copy number gains in CDK6 and gliomas and cortical gliomas. Do you know if your dependency hits were in tumors that had any specific copy number gains for that gene?
Yeah, great question. We checked, but did not see any correlation.
Great.
It was really the neuronal signature, and we also, I didn't show the data, but we checked the cell cultures by single-cell RNA-seq just to make sure they truly have these programs active. And some of them don't, but some of them do. So I think that's also, as a field, something we have to pay attention to. Like before or as you're trying to inhibit something, you have to make sure this program that you're trying to inhibit is truly expressed and there.
Right. Absolutely. Absolutely. Okay. There's a question from Rama from the PBTC asking to Giles, were you able to detect any treatment-resistant mutations in your cell-free DNA in relapse?
Yeah, that's a great question, and that's something that we're starting to look at. Of course, we did note some kind of genetic drift of the tumors, but there are kind of few specimens and stuff to really know whether that's kind of treatment pressure or just natural evolution of the disease in itself. But that is where we think that, not only is this going to be a minimal residual disease detection that you can intensify therapy on or potentially even de-intensify therapy on if it's been negative for some time, but also if you're starting to see some kind of clonal evolution, you may be able to switch therapy or add a more targeted therapy. So I think this cell-free DNA stuff is just fascinating and amazing. I think it's going to pull out more stuff than we can even imagine right now.
So exciting to have this so much less invasive approach to try to see what's happening. It's a really big advance. Very exciting. Yeah. Okay. Well, I think we probably could wrap things up at this point. This has been I think a wonderful session. You guys are certainly demonstrating your rising star status very clearly in this terrific pair of talks. Beautiful research. So I'd like to thank you again for participating today, and I'd like to thank everybody for joining the session. And remind you again, if you would like to join, next week will be the last one of this fall series with Doug Green. So thanks very much, everyone.
Thank you so much.